So for injuries for the hip and thigh lab, we're going to start with iliotibial band friction syndrome. And this is a chronic gradual onset injury, so there's not usually any traumatic incident. They usually can't point to one thing that happens that brought on the pain, but typically something has changed with their activity. They've increased the amount of activity that they're doing, or duration, intensity. Maybe they're going for longer runs or more hill training. They're going for longer bike rides. They got a new bike. If they're a triathlete, for example, and the bike hasn't necessarily been set up for them properly, and it's putting increased stress through the lateral side of the knee. So they're going to complain of pain on the lateral side of the knee, right over the lateral femoral epicondyle where the iliotibial band travels over top. And it may not come on right away when they start their exercise or activity. It might be a half hour or an hour or even a few hours into it when fatigue starts to develop and maybe their technique is a bit off. So if that's the case, we may need to get them to go out and run or bike or whatever activity is that aggravates the knee for that length of time until the pain comes on, and then we'll be able to assess them. So we'll have them walk out 10 steps and walk back for a gait. We'll do our squats and twist tests, tiptoes, knee to wall. We'll do our active passive resisted range of motion, and then we'll get into our special tests. So our O'Bear's test, it's probably going to not come down as low the thigh on the painful side as it does on the non-painful side. So a positive O'Bear's test, they'll have increased pain on the lateral side of the knee as we flex and extend their knee with Noble's compression test. There can be a lot of different causes to iliotibial band friction syndrome, including overpronation, which is why we assess their gait and squat. Tight hip abductors or weak hip abductors can contribute to it. So we're going to test their hip strength with our hip abductors, and we may see that they have weak hip abductors. And TOP, remember, is tenderness on palpation as we palpate over the iliotibial band. So especially over the lateral femoral epicondyle, but maybe along the length of the iliotibial band, they may have pain with that. In terms of treatment, PLE, no compression. We don't want to add further compression of the iliotibial band over the lateral femoral epicondyle. That would just make their pain worse. Addressing any of those biomechanical issues that we identified. So if we found that they have weak hip abductors, then we're going to give them strengthening for hip abductors, like putting a stretchy band or tubing TheraBand around their ankles and stepping sideways back and forth. If we think that tight lateral musculatures, hip abductors, are increasing the tension through the iliotibial band, then we can have them get massage on those muscles, foam roller or rolling on the lacrosse ball. If overpronation we think is contributing to it, taping their arches if that's helpful, more supportive shoes, or even orthotics. So again, whatever you identify as part of your assessment, you're going to have to address or mention in your treatments. Now, out of all the injuries that we cover this semester, we eliminate 4 that are not responsible for your injury scenario. We've eliminated 3 so far: heel spurs, tibial stress fracture, and unhappy triad, and we eliminated a 4th today that I'll mention in a second. I don't tell you out of the remaining injuries which ones are on the injury scenario, so basically you're responsible for all the injuries other than the 4 that we eliminated. But I will tell you that iliotibial band friction syndrome is one of the possibilities. And the reason that I do this is because the first semester that I TA'd, 241, this injury came up for several students. And as part of the history, it mentions they have pain at the lateral side of the knee. So in their mind, they're going back to the knee lab and thinking about the injuries that we covered. Lateral knee, okay, it's got to be lateral meniscus or maybe LCL. So they're doing their tests for LCL sprain and lateral meniscus tear, and everything's coming back negative. So now they're starting to panic, and they're throwing out every single knee test that they can think of, ACL, PCL, patellofemoral pain syndrome, and it's all coming back negative because they forgot about iliotibial band friction syndrome presenting with lateral knee pain that we did in the hip and thigh lab. So what's our key distinguishing feature between iliotibial band friction syndrome and LCL sprain and lateral meniscus tear? They all may present with pain on the lateral side of the knee, but there's a very key factor that distinguishes those injuries, and the key is iliotibial band friction syndrome, chronic gradual onset, so there's no traumatic incident. LCL sprain, lateral meniscus tear, it's an acute traumatic injury. So right from your history, the information that you'll get emailed to you, lateral knee pain, and you'll be told whether it's an acute traumatic injury or a chronic gradual onset. That will help you narrow it down to those possibilities. Our next injury, we'll move on to hamstring strain. So this is an acute traumatic injury. Improper warm-up often contributes to it. Cold weather, dehydration even can be a factor as well. Now, it mentions most often injured in the deceleration phase of sprint. So that's not the slowing down part when you're sprinting. We'll show a video here back from our foot lecture, and we can see as the person is running, when the lower leg is coming forward, even before the foot hits the ground, that forward movement of the lower leg slows down, and it even starts to move backwards before our foot hits the ground. And that's the hamstrings contracting as the lower leg is moving forward, or our knee is going into extension. So the hamstrings are contracting, but they're lengthening at the same time. That's an eccentric contraction, and those are the most stressful for our muscles. So it's that slowing of our lower leg when we throw it forward to stride forward, the hamstrings contracting and lengthening to slow the lower leg down. That's when we strain. They can usually point with one finger to the strain site, and it's going to be a little bit more on the medial side or a little bit more on the lateral side of the posterior thigh. So if the pain is more on the posterior medial thigh, then you know it's either going to be semimembranosus and semitendinosus. You can't determine between the two. If the pain is on the posterior lateral side, it's going to be biceps femoris. So as part of your assessment, depending on the grade of the strain, they might have a limp, they might have difficulty squatting. Range of motion for knee extension is going to be decreased, both actively and passively. And then when we strength test knee flexion, which the hamstrings do, they'll have weakness and there'll be increased pain with that. When we do our straight leg raise, it'll be decreased on the injured side and perhaps significantly for a higher grade strain. Tenderness on palpation when we palpate over the strain site, and for a higher grade strain, there may even be a defect within the tissue, so your thumb might sink down in. You might notice some swelling and even some bruising in the days that follow, and I'll show you an example of that. So this is my leg, and this is 2 weeks after running a half marathon, in which I felt a sharp twinge of pain in my posterior thigh right about here. The smart thing would have been to stop, but I was doing well, so I wanted to keep running. And despite getting periodic sharp twinges the rest of the way, I finished the race. Saw the massage therapist 2 weeks later and reported to him that I did not see any bruising on my posterior thigh, but I only looked the first couple of days. Sometimes it takes a while for the bruising to work its way to the surface, and it may end up distal to where the strain site happened because of gravity acting on the bleeding. Okay, we'll go back to our lab notes. So with our hamstring strain for treatments, police, we're going to work on range of motion, but we don't want to stretch through the hamstring too soon because that's just going to pull apart the collagen fibers and muscle fibers that are trying to repair themselves. So it might be a few weeks before you can do much in the way of stretching. For strengthening, we can begin with isometric. So you could be laying on the ground with your heels up on the couch or an exercise ball if you have one, and pushing your heels down, and that's going to be contracting the hamstring, but they're not changing length, so that's an isometric contraction. For isotonic, our regular hamstring curl machine where you're laying face down and heels underneath a support bar and contracting hamstrings to pull the support bar towards you. And then lastly, our eccentric strengthening is a key part of the rehab for a hamstring strain. And there's a particular exercise called Nordic hamstring exercise. And what this involves is the athlete kneeling on the ground, and you would hold their heels so their legs are kind of fixed to the ground, and they're going to start to lean forward. And as they lean forward, their hamstrings are contracting, but they're lengthening out. So that's our eccentric contraction. Eventually, they're going to lean forward enough that they can't support themselves anymore, and they just fall forward. They catch themselves with their hands before they smack their face in the ground. They push themselves back up, and they start to slowly lean forward again. So research has shown that this is very helpful in terms of returning athletes to sport following a hamstring strain. Quadriceps strain, also an acute traumatic injury. In this case, it is the deceleration, landing from a jump from significant height, absorbing impact, and pain is going to be on the front of the thigh over the quadriceps. Quite often, rectus femoris is involved, so anywhere along the length of the rectus femoris. With quadriceps strain, active and passive knee flexion is going to be decreased, and then resisted knee extension will be weak and painful. If we do our quadriceps length test, so passive knee flexion with them laying face down, the heel won't come as close to the buttocks on the injured side compared to the non-injured side. And if we do a rectus femoris specific one, then it'll be decreased on the injured side compared to the non-injured side. We might even have pain with resisted hip flexion because of rectus femoris helping with hip flexion because it crosses the hip joint. Treatments, police, are gentle stretching after a few weeks, strengthening, isometric, isotonic, eccentric. So for quadriceps, isometric, you could be sitting in a chair facing the wall with your feet right up against the wall, preferably wearing shoes, and then you try to extend your knees. The wall is not going to move, so you're contracting the quadriceps, but they're not changing length. For isotonic, our regular knee extension machine exercise. And then for eccentric, we'll use the knee extension machine and use both legs to bring the weight up, but then we'll pull the non-injured leg weight out from the machine, so all the weight is now on the injured leg, and we slowly lower it back down. Both legs to lift it back up, and then just the injured leg lowers the weight down. So usually they're lifting a fairly light weight compared to what they could do with both legs. Same thing with hamstring strain. For palpation, your thumb might even sink into a defect in the tissue, as we saw in the lecture yesterday. Quadriceps contusion, acute traumatic injury, impact either with an object, a stick, a ball, or another player. Quite often a knee to the thigh will do it. Tends to be a bit worse if the muscle is relaxed. When the muscle or quadriceps are contracted, it can deflect the blow somewhat. This can be very, very painful to the point that people have difficulty weight bearing on the injured side, so they may need to be on crutches. Noticeable limp on the injured side. Range of motion will be decreased, and we may see some swelling, some localized swelling and bruising with the lacrosse guys where they get hit. There'll be a circle where the ball hit, and it's kind of white in the middle and then red all around it. Assessments, again, limp. They're not going to be able to flex their knee, so quadriceps length test will be decreased. Strength for resisted knee extension. They'll have good strength, but it'll be painful, and palpating over the impact site can be quite sore, and it may be firm to the touch. Treatments, we remove them from activity. We can ice and apply gentle stretch through the quads. So sometimes we'll even apply the ice pack with the knee flex slightly so the quads don't tighten up too much. And the gentle compression with tensor wrap. No heat, no deep tissue massage. So we don't want to do anything that's going to increase bleeding into the tissues, because that may send bone may start to form from the osteoblast cells in the periosteum, and the bone will form within the muscle tissue. So if your athlete's range of motion is not coming back as quickly as you think it should, or their pain is not settling down, and the range of motion is staying decreased, then you're concerned that they may have myositis ossificans, which is calcium formation within the muscle. So you'll send them for imaging, and if the x-ray does show the calcium formation, they're removed from activity until the body reabsorbs that. And they'll re-x-ray after, say, 3 months, and again at 6 months, and see if the body is breaking down that calcium. But if it's not, and it's still restricting their range of motion or strength, then they may do surgery to remove that. Which is another reason why we want to protect from multiple impacts. So when we return our quadriceps contusion athlete, we want to pad the area so they don't get another impact into that spot. So our myositis ossificans can be from a significant impact, can be from multiple impacts over a short period of time if we haven't padded or protected that, or they mismanaged the quadriceps contusion and applied heat and did deep tissue massage on it. Okay, so make sure that we're icing, gentle stretching, no heat, no deep tissue massage for quadriceps contusion, and pad the area in return so that they don't develop myositis ossificans. And that is our injuries for hip and thigh lab. Myositis ossificans is the last injury that we remove. So you are not responsible for myositis ossificans, again, because it is an x-ray diagnosis. So heel spur, tibial stress fracture, myositis ossificans are all eliminated because they're x-ray or bone scan diagnosis. And then unhappy triad we eliminate as a possibility for your injury scenario because it combines both intracapsular and extracapsular knee injury, and that's too much to assess for. So that's it for injuries for hip, thigh,